Well, I'm going to let you introduce yourself.
Yeah.
You know.
Yeah, thanks. My name's Andrew Bernard.
Okay.
And I'm from Frankfort. Used to make ambulance runs in Anderson County back when they were a BLS county.
There you go.
And I did make runs for a while over in Scott County.
Okay.
But I've been here at UK since basically 1986.
Yeah.
I'm one of the trauma surgeons.
Okay.
I'm the medical director for the Adult Trauma Center.
Okay. Was that always your plan to come to the hospital, or do you want to stay in EMS?
My mom was a nurse anesthetist.
Okay.
So I really got interested in surgery and critical care, the kinds of things we would do every day, taking care of sick people, a long time ago. So I knew it was going to be something like that.
Yeah.
But it's probably my mentor, Paul Carney, who had the biggest influence on me becoming a trauma surgeon.
Okay. Well, that's awesome. Well, thank you for joining the blood program and helping us get this up and running. I know your expertise is valuable, and we really appreciate you coming on to this and giving us and everyone here some expertise. So we'll kind of start with our protocol. Have you had a chance to look over it?
I have.
Okay.
We're modeling it largely after the Southwest Texas Regional Advisory Committee, right?
Yeah.
STRAC.
Yeah. Yeah.
Everybody talks about STRAC like
Yeah.
it's a deity, which
Yeah.
it certainly is the model that we're all after.
Exactly.
Yeah, I've had time to see it.
Okay, perfect. Well, when we talk about our protocols, and that specific protocol, those indications, when we talk about penetrating and blunt trauma, what are some of those indicators we're looking for when it comes to, do we give whole blood or do we hold off?
Yeah. Remember, whole blood is not for every trauma victim. Whole blood is for trauma victims who have evidence of hemorrhage. I'm very privileged here in that we have all the diagnostics we could possibly want.
Right.
You all on the street are using your clinical acumen.
Yeah.
Now, luckily for us, we have fantastic EMS professionals, particularly in this area, and particularly who are helping start this blood program. But this is on clinical assessment around signs of active hemorrhage.
Okay.
And they're not a lot different than the ones we would use here in the trauma center.
Okay.
We make a decision here in the trauma center within moments of arrival, maybe even before arrival, using your report.
Right.
As to whether we're going to use blood.
Okay.
And the simple methodology we use is hypotension below 90, heart rate elevation greater than 120, penetrating wound to the torso.
Okay.
The only thing we have that people don't routinely have, although I know you all in Jessamine County have dabbled in, is fluid in the abdomen on sonography. Any two of those, we're going to trigger our massive transfusion protocol.
Okay.
And those same clinical signs, somebody with a mechanism that looks like it could be consistent with bleeding in the torso or external or fracture-related bleeding, and physiology consistent with shock.
Yeah.
Those are the main ones. Those are the patients we want.
So when we're in the field, you know, we don't have what you all have in the ER. So when we look at things like end-tidal, when we look at their shock index and things like that, what are those indicators telling you? You know, if we're looking for a high shock index and a narrowing pulse pressure, what does that tell you about hemorrhage?
Yeah, shock index is really valuable. I can throw out a heart rate and I can throw out a blood pressure. And you can think about those two independently, and you can draw an assessment of somebody being in shock. It's because you've been doing this a long time. It's nice to be able to take two numbers and make one number so we can then plot it on a linear scale, just like Glasgow Coma Scale score.
Yeah, right.
I say coma score 15, you would say it's pretty good.
Yeah.
I say coma score 3, you say?
Not so good.
I say coma score 8. Yeah, you're thinking about an airway maybe? That's what's nice about one number we can plot on a linear scale.
Rather than
That's what the
multiple.
shock index gives us. And 1 is a good, easy number, a shock index of 1. Some protocols will use a different shock index, but basically it's that same thing.
Yeah.
It's an elevated heart rate and a relatively low blood pressure. The shock index is valuable. And of course end-tidal, which I don't think we use enough.
Yeah.
You all use it more thoughtfully than I think even we use it here at the trauma center. That's an indication of hypoperfusion.
Yeah.
It's shock. Shock is what kills people.
Yeah.
For the people who arrive here alive and are dead an hour later, they bled to death.
Yep.
So the initiation of whole blood in the field, it's the perfect early intervention for the problem that's preventably killing trauma patients.
Right, and with that, so you talked about how a lot of these patients do end up dying within the hour that they're here. So what do you think those statistics look like when it comes to us starting to give whole blood in the field, do you think those rates of death will decline?
I think so.
Yeah.
Yeah.
Okay, the New Orleans program.
Yeah, it looks almost too good to be true, the study from New Orleans, and who knows, they're bleeding blood. Yeah.
Yeah.
And when I was young, we gave 2 liters of crystalloid right away, and that's how we managed shock.
Yeah.
We always drove fast, which we still do,
Right.
but they're not bleeding crystalloid, they're bleeding blood.
Right.
I think the fact that there are over 180 municipalities now, like ours, who are giving blood in the field, is going to contribute to a massive amount of new data that's going to allow us to really draw firm conclusions. The data from New Orleans is exciting.
Yeah.
It's one study. Is it really that good? I don't know.
Yeah.
But I tell you what, it's a whole lot better than crystalloid.
Yeah.
And if it were me bleeding, I would want it.
You'd want whole blood, right. So when it comes to giving whole blood, what are the benefits of whole blood versus component therapy?
Yeah. We're still unpacking that. It's, from the standpoint of the physiology, I don't think it's dramatically better than components.
Okay.
I think it's somewhat better than components. You know, each of those components, platelets, plasma, reds, they come in their own bag. And in each of those bags, there's the good stuff, the platelets, the plasma, the reds, but there's also a certain amount of solvent that stuff's floating in.
Right.
Put the 3 together, it's a larger amount of solvent, which is probably not a lot different than regular old crystalloid.
Yeah.
Except it probably steals more calcium than regular crystalloid.
Right.
So from the standpoint of the physiology, a unit of whole blood is going to have less solvent, and maybe CC for CC is going to be more impactful than any of those 3 combined or put together.
Okay.
From the standpoint of the physiologic impact.
Okay.
From the standpoint of logistics, though, if you're in the field trying to do 100 high priority things at the same time, we need to keep this infusion, this transfusion, simple.
Right.
And it's beautiful for that in terms of the system of the transfusion.
Right.
Let's keep it simple.
Yeah.
One product that does all those.
Right. Instead of 3 different ones.
Significant system logistics.
Okay.
Definitely better. Is the physiology going to prove out that it's dramatically better? I'm not sure. The evidence suggests it is better than components.
Okay. Good. What about, so when we give, 1 unit of packed, or not packed red blood cells, if we give 1 unit of whole blood, when do we kind of initiate, and go ahead and give crystalloids if they are continuously hypotensive when we're maybe still 30 minutes from the hospital?
Yeah. So the scenario is giving whole blood, persistently hypotensive, and you're wondering if you should give more, something else.
Yeah.
Yeah, that's a great question. I guess what I would use is the guideline that came out now more than a decade ago on guiding pre-hospital teams in volume resuscitation and trauma, which was really simple. Mental status alteration.
Right.
So they've lost consciousness, they have shock to that degree, or lost radial pulse.
Okay.
Now sometimes they're unconscious because they're head injured.
Yeah.
The radial pulse is an easy, reliable one. You can even get it in a moving vehicle, bumps and, road vibration, presence or absence of radial pulse.
Okay.
So they're injured, they're in shock, you've activated your whole blood protocol, you have some clinical response but not enough because they still don't have a radial pulse. I think it would be appropriate to add some crystalloid in that case.
Okay. Good.
That's the best guidance I can give you on that.
Okay.
Because you're right, those people are dancing very close to the edge.
Right. Would you start with maybe a 250 bolus, see how it does?
That's the way I would do it.
Okay.
Small bolus. Give a bolus, pulse comes back, be cool.
Okay.
Still don't have a pulse or lose it again, another bolus. That's
Okay.
beautiful.
How do we start with permissive hypotension? What's your definition of what that looks like?
Yeah, I think that same parameter. You could use
Okay.
that same parameter. Now, permissive hypotension is tough around here because this is a big, busy metro area. 500,000 people in the metro area.
Yeah.
So we're as big as what a dense urban area would have, but we got a lot more blunt trauma.
Yeah.
And these people are not just bleeding in their abdomen or their chest or in their fractures, scenarios in which running the blood pressure a little bit low would be totally okay. These people may have brain injury. So now you're in a little bit of a catch-22. You don't want to drive their blood pressure too hard. Certainly not higher than normal,
Right.
maybe not even too normal with respect to their torso or fracture hemorrhage. But you know if you don't give them adequate perfusion pressure for their brain, they're going to suffer worse neurologic outcome.
Right.
So that's a delicate dance in blunt trauma.
It is, yeah.
In the penetrating torso injury patient, I think you can totally apply those same principles
Okay.
of presence or absence of radial pulse. And I think all the way back to the Bickel trial, the Maddox-Bickel trial, published in 1993 or 4,
Okay.
where they took patients who were wounded with torso trauma and hypotensive and randomized them to whatever the paramedic thought, which in that time was wide open salt water, or KVO.
Okay.
And the whole world said, that's crazy.
Yeah.
You're going to kill people. And in fact, they didn't.
Yeah.
The patients who survived a discharge, much higher in the KVO group. And they actually
Interesting.
spent longer time in the hospital
Okay.
if they got a bunch of fluid. So
Yeah.
shorter time in the hospital and more likely to leave the hospital with KVO.
Okay.
Now that's penetrating torso injury. That's pure hemorrhage,
Yeah.
no brain trauma.
Okay.
So I think the permissive hypotension is much easier in the patient who's doesn't have a brain injury.
Yeah.
Now you ask yourself, okay, well, we squeezing IV fluid in, that's bad. But squeezing whole blood in, why is that not bad? That's a good question. I could see people coming up with that question, and the way I would respond is, the stuff that's in that whole blood carries oxygen, but even more importantly, the stuff that's in that whole blood clots blood.
Yep.
Crystalloid waters down clotting factors, but there are clotting factors in that whole blood. Of the three things that are in that whole blood, the platelets, the plasma, and the reds, I would say the most important part is the plasma.
Okay.
It's that it's going to clot blood.
Yeah.
It's going to patch holes.
Okay.
So that's why that's different.
Yeah. Okay. Well, so in regards to the trauma diamond, we've added that calcium, that hypocalcemia to the
Yeah.
list. So can you talk a little bit about that and why it's been added?
Yeah. So it used to be the triangle, right? And calcium has been added now. These patients are hypocalcemic. And the more we study this, the more we discover they're hypocalcemic.
Okay.
You need calcium to make blood clot.
Yeah.
Now, the two dots we haven't really connected as firmly yet is that giving calcium back actually helps your outcome.
Okay.
We know that patients in shock don't do well. We know patients in shock are low in calcium. We should give calcium.
Yeah.
I think that's the right thing to do because it's not going to hurt.
Yeah.
Does that change outcome? We're not totally sure yet, but that is a new finding in shock resuscitation that I think is really important.
Okay.
And giving calcium's low risk.
Yeah.
Sidebar, kind of like TXA. That's just personal feeling. I think we should give calcium
Okay.
and give calcium liberally. If you're in a massive transfusion situation, if you're giving whole blood, you're in it.
Yeah.
You're in the game deep now. It's time for some calcium.
Yeah. Okay. Good. Let's see. I'm sorry. Hang on. We've talked about a lot so far. I think something me and Floyd had talked about prior to this interview was something about, so we keep our trauma scenes, we try to keep them within 10 minutes. So with that kind of comes with either staying and playing or loading and going is kind of the saying. So how do we balance that line between staying and giving the whole blood and then continuing resuscitation with someone who might have airway compromise and performing RSI? How do we find that fine line of, okay, should we stay and get this airway before we go and do RSI, or do we just go ahead and, hit the road?
Yeah. Wow. Yeah, that's a hard one.
It is.
That's why I have such respect for you all. They need to oxygenate, right? And this is something that Floyd Miracle has commented a lot on, and I've learned a lot from Floyd on his perspective on this. It's about oxygenation. If you can oxygenate and ventilate, you can move toward the hospital while that's happening, rather than definitive airway intervention.
Okay.
I think that's important. So that's an important concept for folks to get their heads around. Because we know, in fact, once that endotracheal tube is in, well, you squeeze that bag and you're just, man, I'm so glad that airway is in, and you give them one big squeeze. That could be quite harmful, in fact, right? Because it's going to increase their intrathoracic pressure, that first big full breath. That's going to flatten their vena cava a little bit. Their venous return is going to be further compromised. So endotracheal intubation is unproven, I would say, in the trauma setting.
Right.
If you can oxygenate and ventilate, I'd be moving toward the trauma center.
Okay.
Remember, the primary treatment of hemorrhagic shock is bleeding control.
Yep.
Right, that's the primary treatment. And you guys have done that at the scene in the form of direct pressure, in the form of tourniquet application for mangled extremity that you can't control with direct pressure. You've splinted fractures.
Yep.
You've maybe placed a binder, or as we call it here, an anti-shock sheet. You've done all those things that you can do to control hemorrhage. Next is going to be giving something that makes blood clot, and you're going to do that with the whole blood.
Right.
I would, as much as possible, minimize the barriers to achieving bleeding control.
Okay.
Going back to our earlier in the interview, our original discussion about how people who arrive at the trauma center alive and are dead an hour later bled to death.
Yep.
Yep, and they probably didn't bleed to death from a fracture problem. They probably didn't bleed to death from external hemorrhage, because somebody with good attention can get control of that.
Yeah.
They bled from something that requires us to get inside their torso,
Something we can't do.
or to angio their pelvis. I can't fix pelvic fracture bleeding. I need an interventional radiologist to do that. All those things are going to, those torso bleeding interventions are going to happen here at the trauma center.
Okay.
So your question was, what do we do at the scene? What do we do on the way? I would say don't do anything at the scene. Don't do anything at the scene that you don't have to.
Okay.
Do everything in the road that you can.
Yeah.
There was this old saying that the most important fluid in the care of trauma patients, for the care of trauma patients, is diesel fuel. Right? That used to be the saying.
Yeah.
I still think that's kind of true, but there's something new now, and that's
Yeah.
whole blood, which is
Yeah.
exciting.
It's up there.
I do a combined resuscitation.
Okay.
Diesel fuel, whole blood. Minimize what you have to do at the scene. I get
Yeah.
the chest open if they look like they have tension. And I'd make sure you can oxygenate and ventilate.
Okay. Good.
By
That's a
whatever
good
method.
answer. Yeah.
It was a hard question.
So in our protocol, we do have, if it is a traumatic arrest that was witnessed less than 5 minutes before our EMS arrival, we go ahead and initiate whole blood in traumatic arrest. So previously it was thought that traumatic arrest shouldn't be worked, it's not worth it, but now we've kind of shifted our view into this new paradigm of we should resuscitate them, and now we should give blood if it's witnessed less than 5 minutes. So how does that whole blood administration change the outcome of this traumatic arrest patient?
Yeah, that's a great question. Because you're trying to be really careful. You're trying to be a good steward of this gift, this blood transfusion, yeah? And you don't want to waste.
Right.
We know that patients who are in traumatic arrest have a very high predicted mortality. And that's true. And working a traumatic arrest when your tools were ventilation, decompressing the chest, and crystalloid, I think that paradigm made sense. But I think whole blood changes that paradigm some.
Yeah.
because you really are giving the ultimate resuscitative fluid. This may be where the red cells also matter, not just the clotting factors in the resuscitation of this patient. And I'm thinking of an analogy with resuscitative thoracotomy. You could say the same thing about resuscitative thoracotomy.
Okay.
And people's support of resuscitative thoracotomy is sort of a bell curve. There are folks who are very, very aggressive with resuscitative thoracotomy, sometimes even in the field.
Yeah.
And folks who are very, I don't want to say nihilistic, but much more, if they've arrested, it's just really unlikely that we're going to bring it back.
Yeah.
And then most of us are somewhere in the middle. I think if there's an opportunity to potentially impact traumatic arrest in the field, it's with whole blood administration. And you're assessing somebody with a monitor and your hands.
Yeah.
You don't know for sure that they don't still have cardiac contractility and a blood pressure of 40 or 50 that you just can't feel. High on adrenaline, terribly injured patient, maybe a scene with more victims, and a brief feel of that pulse. I'm not sure that's enough to say it's over.
Yeah.
So I think your protocol that says, in that scenario that you described, we're going to give it a shot. I think if you ask most providers, I think if you ask most EMS professionals, if you ask most surgeons, we would say it's worth a try. And you know what? As I think about the Kentucky Blood Center's role here, I think if you ask the average blood donor, and they put themselves in that situation as a family, they probably also say give it.
Yeah, absolutely.
I like it.
Yeah. For the services who are terminating traumatic arrest on scene, what would you advise to those services who are now giving whole blood to those traumatic cardiac arrests?
Yeah, so you're describing the scenario of maybe in other circumstances you would work the arrest and then call it.
Okay.
Right, and the question is, we've given whole blood, do we bring as a matter of routine? I would say bring.
Yeah.
Yeah,
Okay.
I would say bring. There are going to be ones that you should terminate
Right.
in the field. It's not as big of a deal around here because you're all in the metro area, not too far of a drive from the trauma center.
Yeah.
In really rural areas, I think that's a little bit different. But there are going to be ones that you wouldn't
Yeah.
work. If you're saying that you think there's enough potential for salvageability that you're going to give the unit of whole blood, then I would load and go.
Worth bringing them.
Yeah,
Okay.
because boy, you don't want to get them back and not be close to the operating room.
Right.
That patient's going to need an operation
Yeah, absolutely.
in order to survive. So bring, I would say,
Okay.
if you're going to work it.
Yeah, I like that. Okay.
Now
Any other
ask your
questions?
question.
Okay. Do you have any other questions you think we should be asking or anything you'd like to add?
No, this is a great list of questions.
Good. Thank you.
This is a very Floyd Miracle list of questions.
It is.
I would just finish by saying so the record shows, whole blood has been something we've been thinking about for a long time, but whole blood in the field, in this area, this comes from EMS, the major initiative. I'm totally supportive, and I'm all in, and the trauma center is all in,
Right.
and KBC is all in.
Yeah.
But the push has come from EMS, which I think says a lot
Yeah.
about the EMS services, the leadership, and the professionals doing that every day in this area. So I
Yeah.
think we're all very fortunate. And I want to express my gratitude for the EMS folks that are out there taking on new protocols, learning new stuff, taking their time to change ice packs and all that to do this really, really well.
Yeah.
This is a heavy lift, and this is going to make a difference in people's lives.
Very exciting. Yeah.
Agree.
Very life-changing.
I agree.
Yeah.
Thank you.